I want to thank all three of you for your outstanding talks about where technology is going in your fields. And we have a brief time. We're going to try to get as many questions as we can. I'm going to hit each of you with one to start. And that is about that we need progress to move forward. You've really convincingly shown the benefit of progressing, but progressing tends to happen unequally. Even in the case of self-sampling, which is designed to promote equity, it doesn't roll out at the same pace everywhere. Could each of you comment on what you think the principal barriers are to disseminating these, and how we might get new technologies out more quickly? Jane, you want to start?
Yes, thank you. And that's an excellent question, because I think every time we have innovation and technology, we have a very high risk of causing the opposite of what we wanted. And like you said, self-sampling also can increase those disparities if it's not done in a way in which we really think about which populations are the ones that are contributing and which are the ones that have the disproportionate burden of cervix cancer. And so we really need to make sure that these technologies and these new innovations are being used in health systems and in communities where access to usual care is the least. And this is going to require that we keep things cheap, that we need to keep things simple. We need to be constantly talking to stakeholders and women and other individuals with services to see what their preferences are. And so I think we really need to think about focusing on communities, focusing on health systems, and really being responsive to what their needs are to make sure that we can adopt this innovation in a way that will actually enhance equity.
Perfect, thank you. Aasma, why don't you go next?
Yeah, absolutely. I totally agree. So I think we have to be proactive and think about the barriers at the patient level, provider, and health system level. So I don't think we can just wait for patients to come and ask for these tests. We really need to be thinking about how we can organize our screening efforts, but then also make it easy, such as mobile phlebotomy, blood draw with other existing tests, and make it as easy and simple as possible.
Yeah, terrific. Christine.
Yes, thanks. Great question. So important as always. I think the first thing we need to think about as far as screening women with dense breasts is, first, we need to just be screening women because we know we have huge disparity there. So before we even think about how are we going to roll this out, how are we going to roll out supplemental screening, we need to think about how are we going to just reach everyone for basic screening mammography. So that's first. We need to do better there. I think we've been held up a little bit by the USPSTF guidelines. Fortunately, at least they have come down on age. 40 for everyone. We know that's really important, particularly when we talk about Black women. They get cancer earlier. So we have to start screening breast cancer earlier, excuse me. Start with screening first. Second, then when we think about supplemental screening, I personally think while, whole full MRI is amazing, that's not going to be feasible when we're talking about 40% of the population, not even to mention equity, but there's just not enough scanner time for everybody, even if we could do it with equity. So that's out. We need to think about cheaper models, probably push contrast mammo. That's fairly cheap, fairly accessible forward. And I think this is really a key area for AI. Because so many women have dense breasts and really never get cancer, we must do a better job of figuring out who actually is it with the dense breasts that are actually at high risk of cancer, and at what period in their life do we really need to. So we need to focus on that period of when they need supplemental screening as well. So we've got a long way to go there.
Yeah, there are related but somewhat different barriers for all three of you. So please we're getting questions in the Q&A section. That's the only place we're looking for questions, so please put them there. Let me begin with some of those. First question from Dr. Villalobos. What's the role of implementation science in scaling and sustaining equitable implementation? Jane, I know you're doing implementation.
Sure, I can
science,
answer.
So
I can answer that, and I
think
I was a little long on my slide, so I had to cut one out. But I think implementation science is actually really key because implementation science is really figuring out, in given contexts, and all contexts are very different, how do things work in those specific contexts, and what are the best strategies that we can use to actually get things implemented. And so it's not going to be, a one size fits all. Every system has its own challenges, its own barriers, its own unique population. And so we really need to use a scientific approach to assessing what that context is, adapting our strategies and rolling things out in a way that we can learn something about, so that every single one of us doesn't have to go back and reinvent the wheel. We can learn from each other and then really, do a better job at implementing broadly.
Thanks. Anyone want to add anything about implementation science? I think it's been a very positive trend. It's been an emerging field that we're really serious to understand how things get implemented, not just do an efficacy study itself. So I think it's been a very positive influence. We then need to implement the implementation findings. And I think that has been a barrier. Sometimes great studies, but they don't always get translated. A couple very specific questions about MRI. One is, does body habitus, does size affect availability of MRI for the breast?
That's such an interesting question. It's interesting because we don't often see women who have dense breasts who also have very large body habitus, because breast density is often assessed as relative to the amount of fat. So more fat density generally goes down. Occasionally we do see it. So if someone really needs screening, again, I'm of the mindset that not as many women need supplemental screening as we think. So it's a very small population of women that would have a large body habitus and extremely dense tissue. Probably contrast mammography is the best option if she's lucky enough to have that available to her. It is more of an issue for women who need diagnostic MRI. So they have a history of breast cancer or very strong family history, BRCA mutation, et cetera, large body habitus. Those women really should be getting screened with MRI. And yes, it is a problem that the MRIs cannot accommodate all body size. That's something that fortunately MRI manufacturers are working on, but needs to go faster given the population in the country.
Yeah, great point. There was also a question about if you're going to do supplemental screening, because let's talk specifically about the extremely dense breasts, the densest of the group.
Yep.
Do we have any idea what the right interval is? Is it every year that you continue that?
It's every year. And there are some loose recommendations saying that. And we know that based on several things, tumor biology, the time intervals over which cancer forms and then spreads. Obviously, the goal is for us to catch it before it is spread to the nodes. So we want it to be every year, ideally stage 1, early stage 2. So should be annually.
Yeah. That was an interesting finding, recommendation in the draft from the USPSTF. I think everybody really glad to see the recommendation for 40 and the simplicity of it, but really not so happy with the every other year, particularly in the premenopausal group, because we know, and they acknowledge that that's associated with worse prognostic features, statistically significant. So it'll be interesting to see during the draft period. Let me ask you all a question, and Aasma, I'm going to start with you. And that's about cost and coverage. And I think the new blood tests are really a place where they have to be practical. They have to be affordable. To be affordable, they have to be covered. People are really interested in what data, what level of evidence we're going to need. So it's a really tough question, and I'm curious how you're thinking about it.
Yeah, absolutely. So given all the enthusiasm and ongoing studies, in its wisdom, CMS actually came up with a national coverage decision, as you know. So they said they would cover a test, meaning pay for a blood-based test, if it meets the 3 criteria: sensitivity of at least 74% for colon cancer, specificity of 90%, and FDA approval. So, as these companies look to meet or exceed that bar, we do expect Medicare to cover it. And by extension, most commercial health payers will follow suit. So we're hoping it very rapidly becomes one of the screening options that's offered completely free and cost-free. Because frankly, that's, one of the biggest barriers is cost. So we have to remove any cost barriers or perception of cost barriers by making it free and easily available. Yeah,
one of the, I often cite the self-screening HPV as an intervention that in part was specifically designed to be affordable and promote equity. But then you look at some of the supplemental screening for breast cancer, which has additional cost associated with it. So it's a complex equation, of how we advocate and increase availability. One of the challenges in making these technologies widely available, and the participants, we have a big group, and they touch a lot of systems. Should each of our participants and attendees be more proactive, either with the clinicians in their area, with the hospital systems that they're associated with? What can we do to accelerate awareness and uptake of some of the new technologies? Christine, maybe you ought to take that one first.
Yes. So I think part of what we can do is use it in distinct populations. So I think part of what hinders it is, and we've seen this with MRI, and now we're already seeing it with contrast enhanced mammo and abbreviated MRI. When it's first tested, it's self-selecting. Patients are self-selecting, even for the trials. And so it winds up being tested in this little niche group, and it just, propagates some of the same issues that we already have in medicine. So whatever institutions can do to either when they're doing the studies, be incredibly proactive about really making sure that this is tested across broad populations. I mean, we think we should have learned our lesson with screening mammography, where, it's water under the bridge at this point. We have all these randomized control trials that we will never again be able to repeat, and they were all done in white women. So too late. But we continue to make those mistakes. But things that my institution is doing, such as abbreviated MRI, is very well proven now at this point. So do whatever you can, either through grant funding, institutional funding, et cetera, to fund it in other populations that are not taking it up as quickly. So prove its utility across the board. Really have the cancers detected, show that they're detected at early stages, and I think that really helps both in the community and the hospital appreciate its value.
Yeah, Jane or Aasma, you want to add anything to that? We're good. Okay. One very specific question about still with breast cancer was Georgia Hodge asked that she was diagnosed with breast cancer at 32. And is there going to be a change in the age for when Black women should start breast screening? It is a stunning number when you look at non-white women, and it's not just Black women, but non-white women, how much earlier the average age of diagnosis is. So I think we will see a re-embracing perhaps of 40. There's always been an option to start at 40, and Black women should have been starting at 40 in almost all cases, I think many would say. Do you think it's going to go even younger? Do you think we're going to have to consider in the next decade 35 for some populations?
I think it probably should be younger for Black women. I actually just looked at all the data and served as the radiologist on the American Society of Breast Surgeons, putting out new guidelines based on evidence that we have specific to Black women. We run into the exact same problem, and it's what the USPSTF, I'm not thrilled with their recommendations for years, but it's what they've gotten hung up on, which is we don't have data to derive these guidelines. So there really is no data showing mortality benefit under 40, and definitely not for Black women, much less, women on the whole. So it's really hard to say that. But yes, when you look at the mean age is 4 years younger in Black women, it becomes very hard to say how are we not screening them younger. I think what we do have data to say is that it is essential that other groups too, but specifically Black women, are screened for high risk by whoever they see, their OBGYN, their PCP, et cetera. Now we're saying it needs to be done by 25, as we're seeing so many cancers in younger women, to at least identify family members and things like that who may have had breast cancer.
Yeah, and just to be clear, that's specifically in the BRCA group, very strong family histories, radiation, the very high risk group.
That's exactly right.
Yeah.
That's exactly right. But even, if they have one relative and might put them in that 15 to 20%, that 15 to 20% lifetime risk area is the area where we're seeing evolution. We're seeing now some are suggesting you should get screened with MRI. You perhaps should get screened earlier. So those women too.
Yeah, got you. So there's a question for each of you. It's a wonderful question from Laura Fox about the use of population management. No, she, I think it's a she, specifically asked about the use of digital automated reminders. I'm generalizing it to population management in general. And it just is not, relying on primary care alone, or OBGYN, we've done an amazing job, but it's never going to be sufficient. If, there are people who do not have a regular source of care, the primary care may be in a setting where it's just very, very hard to organize screening. So we're going to need population outreach. and anything that of particular excitement or promise and I particularly worry about the smaller systems, the rural hospital systems that are financially stressed, may not be able to afford a population health team. So I'm giving you a lot of challenges. Anybody have any good solutions for getting population management out more broadly? Jane, go ahead.
Yeah. Oh.
No, absolutely. I mean, I think there's a lot of room for population management, but I do think that in the area of cervix and colorectal, we see that there are many opportunities for encounters in health systems, in FQHCs, in safety net settings. Underscreened women sometimes might not come in to see a healthcare provider, but often they come in quite regularly from other health issues. And so we really need to have a system that allows for opportunistic encounters, and having sampling, having stool-based sampling, blood testing sampling, for example, will make it possible to use those opportunistic encounters to get the screening done. So
yeah, awesome.
I'm very enthusiastic about that.
Yeah. Aasma, I think you wanted to add as well. Aasma, did you want to add about systems of screening, population management? Anything that you want to add? Not sure she's hearing me. So, all right, let's forge ahead. So there was a question about low and middle income countries, particularly around cervix cancer. And Jane, you could tell, I'm not sure that the audience knows where you are right now, so you may want to comment where you're sitting as you answer this. But tremendous inequities in cervix cancer from an international standpoint, probably more inequities in cervix than we see in many other cancers, and remains either one or two as a cause of cancer-related death in low and middle income countries. So just give us your thought about how to disseminate technologies. And again, I think in the case of HPV self-sampling, maybe the lower middle income countries are showing us the way.
Yes, thank you. That's an excellent question. And I'm in Zambia at the moment. So very excited to be over here learning about the screening and cancer care system here. But yes, I think low and middle income countries in many ways are actually leading in this area. We in the US seem to be dragging behind because of our regulatory environment. Many countries already have implemented this. And I think, so what's this going to require? Currently, HPV testing is expensive. And because of that, it really is conducted primarily on larger machines that are only found in centralized laboratories and whatnot. So I think really the work that is really going to have to be done in the future to really scale up self-sampling and cervical cancer screening with HPV, which is what we want to use because it's a high precision and it's just a superior test, is really figure out how we can have cheap, affordable, easy to use point of care tests so that we can do the sampling on spot. And in that same visit, have the person leave with their test results, and better yet, have leave with already a treatment already done in place. So testing and treating on the very same visit. So I think I think an exciting area of work is really in this development of point of care testing.
How far away is that? Any idea?
Oh my goodness. We will have Dr. Catherine Kunrad on at the very end of the dialogue today, and this is all imminent. The work that's been done is just it's mind-blowing how fast it's been done, and really, COVID has been actually something in the world of point of care diagnostics has actually been something wonderful for us. So I'm very hopeful that we'll have cheap, affordable, and easy to use low infrastructure options very soon. Yeah,
that'd be awesome. Aasma, while you were technologically challenged a little bit for a moment, did you want to add anything on any of the earlier questions about population management or outreach?
Yeah, so I think population health is the way to go. And, we've already started doing proactive approaches in our healthcare system. There's no reason we can't identify these individuals that are screen eligible and are either due or overdue. So then it's a matter of putting together a program where we can reach out proactively. There's several digital health solutions in this space. So sending text messages, letters, and then making it easy to kind of do telephone reminder calls. So those are some of the tools that healthcare systems should be using, and they actually have great evidence behind them that they actually do work.
Again, yeah, I think they're real difference makers. And again, it becomes an equity challenge, because you need some investment, behind the scenes. It's hard to do that office by office. I really worry about rural America in this nation in doing that. I think partnerships between larger centers and smaller centers are going to be critical in the future. I think we're not going to be able to just take care of our own catchment areas. I think the larger centers are going to need to partner with a network and make sure that help disseminate. We're right near the end. You each get a 20-second kind of final word about where you think the real opportunity is in disseminating technology. Christine, you get to go first. Well, you're on mute.
Oh, I just wasted 10 of my seconds on mute. Two things. I think cell phone platforms, whether it's linked to healthcare or anything else nationally, basically it needs to be bundled. So reminders for all the types of screening, we cannot continue to tackle them one at a time. Along those notes, a lot of, again, rural is an issue, but a lot of cities have done amazing work bringing the healthcare into the community in some sort of mobile form. Again, that often makes the mistake of targeting one thing. So uniting all of that mobile care together, setting them up with primary care. And, we've done that here in West Philadelphia now several times, providing all sorts of cancer screening. I think that's a second good approach.
Awesome. Aasma.
So I think population health solutions such as, text reminders, there's automated phone calls, and again, having clinics in charge of pulling these lists to figure out who from their panel is due or overdue. Even if they're not going to come to clinic, we need to reach out to them. So, using one or multiple tools is truly the way to go.
Awesome. Jane, you get the final word.
Excellent. Yeah, I think really honing in on the populations that need these interventions most and making really, I hate to use the cliche term, but precision public health, making sure that the areas with the highest burden are the areas where we really focus our efforts and make sure that we can get these important innovations to them.
Awesome. I know everyone joins me in thanking each of you. Tremendous comments, great panel. Thank you to everybody who put outstanding questions. We hit most of them in one form or the other, so I appreciate everybody moving so quickly through that. And thanks again for a great panel.